Good morning, and welcome to all of you to Covering Kids and Families presentation of the elections over what's next for healthcare reform. My name is Danielle Zirkel, and I'm a healthcare outreach specialist with CKF, and I will be moderating today's events. CKF is a statewide coalition comprised of many of you listeners today. We have representatives from UW Extension, from state and government entities, from healthcare providers and agencies, nonprofits, and social service agencies. And we're so excited that you're all joining us today. It's been a very exciting and very confusing time since the Affordable Care Act was passed in 2010, since the Supreme Court upheld its constitutionality this summer, and since the elections just a few weeks back. So we're hoping today's presenters will try and make sense of a lot of that information for you today. So with us today, I have Roberta Riportella from UW Extension. I have Jennifer Sullivan from Enroll America that's joining us remotely. I have John Peacock from Wisconsin Council on Children and Families, and Mary Meehenstrube from UW Extension. So our goals today, it's our hope that these speakers will help you understand the impact of the elections on the implementation of the Affordable Care Act at a national, state, and local level. Our speakers will share their perspectives and also introduce a variety of resources that they utilize to help them make sense of the Affordable Care Act. And obviously we understand that our audience is comprised of a number of different participants, and we can't go over everything that we'd like to today, but we hope this is a jumping off point to start the conversation and continue it after the presentation. So this is our agenda for the day. Just note that I will be taking questions throughout the presentation. You can use the link on the left-hand side, I think it's a speech bubble, to email in questions at any time. And then there's also an email tab that you can click on immediately if you wish to invite other people to the webinar. So now I'm going to turn it over. I'd like to introduce CKF Project Director, Professor at UW-Madison School of Human Ecology and Health Policy Specialist at UW Extension, Roberta Riportella. She's going to provide you with an overview of the Affordable Care Act, just to get us all on the same page as we start off today. Roberta?
Thank you, Danielle. Okay, so the Affordable Care Act, Patient Protection and Affordable Care Act, ACA, Obamacare, PPACA. It's health care reform regardless of what words you use to call it by. It is the law of the land. It passed on March 23rd of 2010. It was challenged, as we all remember, constitutionally, but it's been upheld. Basically, the U.S. Supreme Court said that the individual mandate is constitutional because imposing a fine for not complying is considered within legitimate federal taxing authority. States do not have to expand their Medicaid programs, however, which was another part of the Affordable Care Act. It's big. It has 10 provisions with implications. These provisions can be found on the healthcare.gov site, and these and all of the other URLs, websites are going to be listed at the end of the talk, and they will also be up on our website so that you can get to them at a later point. But you can see the range of things that are covered here. This is a slide also from the healthcare.gov site looking at what's changing and when. I find this a very useful resource to just get a sense of how much has happened over the past 2.5 years, and so you can see what's been put into place and what's coming up next. What the law does. In very general terms, it modifies current existing insurance policies to improve coverage for those who have it, to secure some coverage for those who do not. It's basically a legislative response that allows us to regulate insurers, protect consumers, and put in place new insurance entities. It is leaving the current free market health insurance system generally untouched. A lot of consumer protections put in there, but basically things that are in existence today will remain in existence. It provides new eligibility rules for Medicaid, and it creates changes in Medicare. Most people don't understand, though, that the Affordable Care Act also offers lots of guidance, support on preventive care, on access to care, on the infrastructure. There's workforce development, there's cost-efficient care, new delivery systems such as the accountable care organizations. It also provides grants to various groups and organizations to improve the overall healthcare system through innovative interdisciplinary expertise. Know that there is a large outreach component in this, and CMS, the Center for Medicare and Medicaid Services, is responsible for this part of the implementation of the Affordable Care Act, and they have funds to contract with lots of organizations around the education that's needed for the public right now to make this law a reality. And it's one of the reasons why we are partnering so closely today with our extension partners, particularly from a county perspective, and Mary Meehan-Stube will be with us to talk about that. It does change some options for the publicly insured, and it's moving more uninsured individuals to insurance, which is the main thing that most people think about when they think about health care reform. It was a way to expand insurance to the uninsured, and it does that by mandating individual coverage, by having what they call a shared responsibility of an employer-based coverage, so that some employers are required to help their employees gain insurance. I'll talk about that in a bit more detail in a second. It removes barriers to current coverage, and it increased lower cost group options in exchanges and in high-risk pools, which are actually on their way out. Come 2014, we will no longer need them, and the exchanges will take over. So the insurance reforms affiliated with ACA, there are these preventive aspects. So there's free preventive care for those with insurance. We may remember that this July there was a big hubbub about this when a lot of preventive services were going to go into effect. Just a note, they really don't go into effect until your plan year changes. So for instance, for those of us on the state of Wisconsin's policies, they will go into effect January 1st of this year. But this was an implementation part of the grant that said that all insurance plans have to cover preventive care benefits. The financial aspects to the insurance reforms, there's some financial assistance for seniors in paying for prescription drugs. There is no lifetime limits on coverage. That's now taken out of all of the insurance plans that those of us have been on. There are tax breaks for small businesses to help them provide coverage, and I'll detail that in a second. And there's also access to insurance. Perhaps if I had done a survey beforehand, I could have known that the most popular part of the Affordable Care Act is that young adults are allowed to stay on their parents' private insurance plans until the age of 26. There's also parts of it that say that right now, children cannot be denied coverage for having a pre-existing condition. And that means that all children can gain access to insurance right now without having the barrier because they're sick of being turned away. As we roll into January of 2014, most individuals will be mandated to have insurance, but the government will provide tax credits to some who can't afford it. There are going to be some who are going to be exempt and not have to actually be mandated, or they'll be mandated and exempt from the mandate. There are going to be individuals without access to insurance who that can now purchase coverage through an exchange. There are adults who won't be able to be denied coverage for pre-existing conditions. I'm going to spend just a second talking about this because I realize that we've been talking a lot in the news about pre-existing conditions, and that won't be a barrier to care. I think it's really important for people to understand that this has been a major barrier to getting health insurance for lots of people. If you have asthma, if you have diabetes, if you have a mental illness, there have been all sorts of ways which insurance companies have been able to say, no, you are uninsurable. And so, or that the premiums have been so high that it's basically been unaffordable. What the Affordable Care Act does is requires that insurance is offered to everybody regardless of any pre-existing conditions. They are only allowed to base their rates on age, tobacco use, family size, and geographic location. They are not allowed to base it on an illness that you have, and they're not allowed to base it on gender, which has been a big plus for women who have always been charged higher insurance rates. So the fact that the Affordable Care Act is now requiring larger purchasing pools, more people are going to be grouped together, is going to allow for insurance companies to even out the premiums across people so that pre-existing conditions will no longer be a barrier. The other thing on this slide says that states can choose to cover more individuals by expanding their Medicaid programs. I will leave that to my colleague John Peacock to talk about how that worked out in Wisconsin. I think about this as a three-legged stool approach. In order to get to full coverage, we have employer-based coverage, we have exchange coverage, and we have public program coverage. And if we think about it as a three-leg stool, we understand that when one leg doesn't work that well, then the whole stool may fall down. To remind us, in the U.S. right now, most of our insurance comes through our employer-based insurance. You could see over about 176 million people are insured through an employer-based system. Some people do have to buy insurance on their own. Those are the direct purchase folks. And then we have the Medicaid, Medicare system. And over in the corner, we have right now, about 53 million people who are uninsured. This is what insurance is supposed to look like when reform is done in 2014. And the blue area is employee-based coverage without tax credits, and that's above 400% of the poverty line. The peach area are those people who we expect to stay in employer-based coverage with some tax credits. The pink area in the left is those that are probably going to be in, say, like our Badger Care program, and those are the children that are still there. And the darker blue area is those that were supposed to be on Medicaid under 138% of the federal poverty line, and the green over in the right-hand corner is Medicare. So this was how we were going to reach complete coverage. The employer-based system. ACA expands on this system by giving tax credits to small businesses for insuring employees. It fines large employers for not insuring employees, and it requires the very largest employers to insure by providing employer-sponsored plans. Now, this little note on the bottom about what the Congressional Budget Office estimates, I've included in here because there have been lots of discussions during the election that we were going to lose employer-based coverage if we didn't repeal the Affordable Care Act. And just so we understand how misleading that particular statement was, it made people think that people weren't going to be insured. The estimates coming out of the CBO in 4 very different scenarios do so show changes in how people would be insured. So yes, there may be a decline in the employer-based coverage, but that was because there were going to be increases in people getting their coverage through the exchanges and through Medicaid. So it wasn't a loss of coverage, it was just a change in how people were going to be covered. Small businesses. Oh, I took this slide from our colleagues at the Commonwealth. I thought they did a nice job of putting this together. It's a reminder to us of who is really not insured now and why we needed to really help small businesses and their employees. So for employees making less than $15 an hour, their employers are only offering 54% of them are offering insurance to their employees. And out of that, only 34% of those employees are able to afford that plan. Compared to those earning more than $15 an hour, where 71% of those employers are able to offer a package and 70% of those employees are able to purchase it. So this is a reminder that this is what's going on for small businesses. So to help get out of that conundrum, the small businesses can receive tax credits. And there's some specifics here. So if an employee's average wages are less than or equal to $50,000, then the employers must pay at least 50% of the employee's premiums, and the employers can receive up to a 35% tax credit. Now that's only if they choose to. Any employer less than 50 does not have to offer insurance. back to this three-legged stool, let's look at the exchange coverage. The exchange is really a new marketplace. It's a place for individuals and small businesses to shop, where they're going to find standardized insurance products, perhaps better peace of mind, and tools for comparing those options and finding the best plans with strong insurer oversight. Under the Affordable Care Act, those small business exchanges are going to enable small companies to offer a selection of affordable health plans to the employees, and the tax credits are going to help out here to balance out the premium costs. Another great slide from Commonwealth to remind us of who is really left out of the current insurance market, and it's mostly those people who are working in small businesses, usually low-income workers. 66% of them have been turned down or charged a higher price or excluded because of a pre-existing condition. They report that it's been very difficult or impossible to find coverage they need, or find it very difficult or impossible to find affordable coverage. 44% of the workers who tried never bought a plan on the individual market. Hopefully the exchanges will now fix that particular barrier. A lot of people have been concerned about the mandate and whether or not such a mandate can work. We understand that the mandate is an attempt to increase the number of healthy people in an insurance pool, to balance it out so that the insurers feel comfortable offering a product to people, some of whom are healthy, some of whom they know are going to be sick. And that's the reason why the premium rates can be smoothed out. So in order to get enough healthy people into the plan, there is this mandate. And we know from evidence in Massachusetts that the mandate works at least to decrease the number of people who are uninsured. In 2003, they had 10% of their population uninsured. By 2009, it was under 3%. So the mandate has worked in practice in encouraging people to get into an exchange or some type of health insurance. And the last leg of this three-legged stool is the public programs, and these are Medicaid, our CHIP programs in our state, that's Badger Care, and Medicare. It also includes the VA programs and the Indian Health Service. And as I mentioned, John will be talking to us more in depth about what happened to the population that is affected. But what I want to focus on is the fact that ACA did not provide an affordable alternative for people who might have been included in Medicaid, so that there aren't subsidies available to that population under 138% of the poverty level. That was not initially written into the law. This leaves many who are likely to be uninsured and what Meryl Guzner has called the new donut hole of health reform. There are other things, though, that did stay in effect with Medicaid. That has to do with increases in primary care provider payments. It provides new options to expand home and community-based services. It gradually reduces the disproportionate share hospital payments that I believe John will talk a bit about. And it required a maintenance of eligibility compliance, which the states are now dealing with and negotiating with the Department of Health and Human Services over. The other final parts that I want to mention that are in the Affordable Care Act that I think are particularly important for those of us that are going to be working at the community level is that there's a lot of personal and social responsibility built into this act. It requires for the person to make healthy choices for oneself and for the government and communities to help that and to be responsible on their end. So in terms of rewarding personal responsibility, Medicare and Medicaid enrollees will be rewarded for completing behavior modification programs. Medicaid will cover if somebody goes to a smoking cessation program for pregnant women, free annual wellness visits for those on Medicare, and preventive plan services and health risk assessment, and all those free preventive services now for all of us on insurance. Those are all incentives to help us take personal responsibility for taking care of our health. Also know that there's been created a national council to coordinate federal prevention, wellness, and public health activities, And there's new prevention research and health screenings, education and outreach, and lots of new dollars associated with it. There's promoting health in the workplace, giving grants to employers for up to 5 years of wellness programs, grants for employers to reward employees for entering wellness programs, requiring chain restaurants to state nutrition content on all items, and requiring break times at work, and also offering a separate location other than the restroom for breastfeeding. So all of that is promoting health at work, generally making communities healthier. There are community transformation grants that are out there. These are competitive state grants for preventive services to reduce disease and address health disparities. There are grants for more community workers. There are individualized wellness plan projects. So a whole composite of different things that are part of the Affordable Care Act that recognize that this grant is not just about insurance. It's about moving us all to really think about what individuals, families, and communities do to create health. And yes, health insurance is a major piece of that, because when the promoting and creating health doesn't work, or when we need screenings, there needs to be that safety net behind us of a workable healthcare system that people have easy and affordable access to. So the Affordable Care Act does all of that. Thank you.
Thanks, Roberta. So I hope that overview provided at least a good solid basis of what the Affordable Care Act is. We do have a couple questions that have come in, but I want to go ahead and move on to our next speaker, because I think some of these questions will be answered as we go through the rest of the presentation. So I'm